I am Dr. Karthik Kumar, endocrinology faculty at Doc Tutorials. You know, we the team Doc Tutorials are going to launch the medicine residency program, of which you have heard a lot about through the promos and the WhatsApp messages that we have received. And in the last 1 week or so, we have had a multiple trial sessions conducted by our various national faculties, and to give you a feel of how the residency program is going to be planned and how the sessions are going to be like. So when we initially decided on such a program to be based on the medicine curriculum for the residents, a lot of students have asked me, so what is actually the difference between the NEET assess training program and such a curriculum based residency training program? We already have a full-fledged NEET assess and INISS preparation course in place. And what is the need for an additional program over and above that? So I think you will get a clear answer by seeing today's session and how I go about differently for a NEET SS session as well as for a curriculum based residency session. For a resident who is in his first year, second year, or even final year, there are majorly two goals. One, to complete the residency with a good mark, get adequate clinical knowledge so as to enable him or her for a good future practice, as well as to prepare well and perform well in the NEET SS and INISS examination. I've always believed that the foundation that you have laid in the 3 years of your residency is the most crucial thing determining your success in the entrance examination as well. Entrance examination, as you know, is just a screening process for your entrance into super specialty courses, and it doesn't determine your future. Your future will be determined always on that, and that is the thing that will take you to more high take you to heights rather than your MCQ solving approach. So here, in order to give you a sneak peek into the residency program that we have already recorded, we will be giving you a mock session here. In the topic that I have chosen for that is adrenal. I too, as a medicine resident, had so much confusion regarding how to approach a patient with suspected adrenal insufficiency and how to go about a low serum cortisol level. So I through this is intending to prove to our discussion. As you know, this is YouTube live session, and in case of you having any doubt whatsoever, you can you can feel free to type that in the chat box, and I'll be happy to take the questions. So just the initial slide, the adrenal gland, has an outer cortex and an inner medulla. The cortex is further demarcated into three fasciculata, which is also the largest layer, which secrete glucocorticoids or cortisol. And you have the innermost part of the cortex, which is the zona reticularis, responsible for the secretion of adrenal androgens. 90% is contributed by the adrenal cortex, and the inner 10% is formed by the adrenal medulla, which secrete catecholamines, the adrenaline and noradrenaline. So adrenal insufficiency is predominantly a disease of the adrenal cortex, even though the adrenal medulla can also be involved. So predominantly, when you say adrenal insufficiency, that is adrenocortical deficiency. But there can be variable involvement of medulla as well. Now, this is the hypothalamo-pituitary adrenal axis that you all know about. You have the hypothalamus, which produces the corticotropin releasing hormone, which stimulates the pituitary pituitary to secrete the ACTH present on the surface of adrenocortical cell to produce cortisol. Cortisol is the principal steroid produced by the adrenal gland. And this cortisol, in order to avoid the excess production of cortisol in our body, is tightly regulated by a negative where the exert negative to the pituitary and hypothalamus. See, is said to be present. Decreased production of one or for practical purpose and for evaluation, you want a specific definition for adrenal insufficiency. So, the single most important component in adrenal insufficiency is glucocorticoid deficiency. So there can be variable deficiency of glucocorticoids, mineralocorticoids, adrenal steroids, epinephrine, norepinephrine, all these things. But the cardinal point or the factor that helps you to make the diagnosis of AI is the presence of glucocorticoid deficiency. So, in other words, you can say that adrenal insufficiency is nothing but adrenal glucocorticoid deficiency with or without other hormone involvement. This is the applicable definition in most cases, and this is very, very important for you practically also. This is how you should make a diagnosis of adrenal insufficiency. Now, adrenal insufficiency, as you know, is divided into primary AI and central adrenal insufficiency. Central means it can involve the hypothalamus as well as pituitary. So this is one area where many of the residents or students or practitioners confuse. They may think that this adrenal insufficiency is the same as Addison disease. Addison disease, the terminology you must have heard a lot, and some equate adrenal insufficiency to Addison disease. Just have a look into that. So, primary adrenal insufficiency means the defect lies at the level of adrenal, and this is what you call Addison disease. So, all cases of adrenal insufficiency cannot rise at the level of adrenal, is called as So in central adrenal insufficiency, which is due to pituitary or hypothalamic cause, you have low cortisol, normal aldosterone. So this point is very important. Why aldosterone is normal in central adrenal insufficiency? It is because aldosterone is not under the control of ACTH. Rather, it is the renin-angiotensin aldosterone system which is responsible for the aldosterone regulation. So in primary AI, both cortisol and aldosterone will be low, whereas in central AI, that means in pituitary or hypothalamic cause, there will be low cortisol, but the aldosterone will be normal. Consequently, there will be low sodium because of glucocorticoid deficiency, but the potassium is remaining in the normal range. So this is one important pointer to differentiate between a primary adrenal insufficiency and secondary adrenal insufficiency. Now, just look at this example. So this is a patient with fatigue, weight loss, and hyponatremia, and you suspect adrenal insufficiency, obviously. So the serum cortisol that we have checked is extremely low. It is 0.8 microgram per deciliter. And the plasma ACTH is 21 picograms per ml. So of course, you have to know whether the patient is having AI or not and what is the type of adrenal insufficiency. So very low cortisol in the presence of a suggestive clinical setting, it makes the diagnosis of adrenal insufficiency more likely. Now, the question that you'll have to answer is whether this is a primary AI or a secondary AI. Now, look at the ACTH level. You expect that in central adrenal insufficiency, the ACTH level has to be very low. That is the usual concept that you have in your mind. But actually, what happens is that when the cortisol is low, you expect the loss of negative feedback inhibition on the ACTH and CRH. So if the cortisol is low, then usually you would have expected a very high levels of ACTH due to the lack of feedback inhibition. But here, that increase in ACTH is not happening. In fact, ACTH is kept within the limits of normal. So in a patient who is having adrenal insufficiency and the defect lies at the level of adrenal, the ACTH should be more than 2 times the upper limit of normal. That is arbitrarily above 100 picograms per ml. So this is how you diagnose primary adrenal insufficiency. That means the patient is having low serum cortisol with high plasma ACTH, more than 2 times the upper limit of normal. So anything below that, a patient with low serum cortisol and an ACTH level less than 2 times the upper limit of normal. That means the ACTH may be inappropriately normal or sometimes be low. So the take home message from this slide is that the secondary adrenal insufficiency need not have very low ACTH level all the time. The ACTH level need not be less than the lower limit of normal. It could still be in the normal range and it can still be a secondary adrenal insufficiency. So if the patient is having primary AI, then definitely the ACTH levels would be more than 100 picograms per ml. So the other investigations to help you differentiate between a primary and secondary AI, apart from ACTH level, is of course the aldosterone levels, because aldosterone is intact in secondary AI, and also the potassium level. Now let's look at the causes of adrenal insufficiency. So the commonest cause of AI overall, combining all the primary and central AI together, it is central adrenal insufficiency. That too due to the exogenous steroid use. So the exogenous steroid use would cause an endogenous suppression of your HPA axis, and the steroid withdrawal would result in adrenal insufficiency. That is the most common cause worldwide. And the most common cause for primary AI or Addison in India is tuberculous adrenalitis. So the tuberculous infiltration of the gland producing AI is the most common cause, whereas the most common cause of primary AI overall in the whole world is autoimmune adrenalitis due to antibodies directed against the 21 hydroxylase enzyme. Then the cause for the primary AI in children, the most common cause is congenital adrenal hyperplasia. Sorry, it's not congenital adrenal insufficiency, it is congenital adrenal hyperplasia. Then the most common infectious cause of AI. Actually, this is a bit of a controversy. If you look at the literature, you could see that TB is still the leading cause of, or still the leading infectious cause of adrenal insufficiency worldwide. But the Harrison has mentioned HIV infection. So HIV infection per se, it is rare to have adrenal insufficiency. But if you look at all the causes, all the probable causes of AI in a patient with HIV, like a patient with HIV can contract tuberculosis, there could be drug-induced adrenal insufficiency, like with rifampicin and ketoconazole for fungal infections, etc. There could be disseminated fungal infections like histoplasmosis, coccidiomycosis, etc. So all these things put together, like CME adrenalitis, all these things put together, then maybe HIV adrenalitis, HIV infection could be a common cause, but it is not the HIV infection per se. It is the sum total of all the opportunistic infection, HIV infection related, drug related, everything come together. Then maybe HIV could be the most common infectious cause. Now, coming to a very important point, steps in adrenal insufficiency evaluation. So the first step is to know when to suspect or when to think of adrenal insufficiency as a differential diagnosis. Next, you will have to confirm the diagnosis of AI, then to categorize into primary and secondary adrenal insufficiency, and finally the etiological workup. Now, first we'll look at when to suspect adrenal insufficiency. Adrenal insufficiency can have an array of features like the glucocorticoid deficiency, the mineralocorticoid deficiency, as well as ACTH excess. So these three applies for primary AI. So when glucocorticoid deficiency, the patient may have fatigue, weight loss, and worsening of these fatigue, lethargy, everything during periods of stress. So during fever or stress, the patient could have worsening of these symptoms. So this is classical of glucocorticoid deficiency. And what are the biochemical features of glucocorticoid deficiency? The patient will have anemia, eosinophilia, and hyponatremia. So of this, hyponatremia is the most clinically apparent and striking biochemical finding, because the finding of anemia, eosinophilia are highly non-specific, and hyponatremia is possibly one of the most common indication for which you seek the evaluation of adrenal function. And regarding mineralocorticoid deficiency, the features again include fatigue, salt craving, low blood pressure, and postural dizziness. And what are the biochemical findings of mineralocorticoid deficiency? They include hyponatremia and hyperkalemia. So why hyponatremia, hyperkalemia occur in AI, we have already discussed. And the feature of ACTH excess is hyperpigmentation. So why do ACTH excess cause hyperpigmentation? It is by the excess ACTH binding to the melanocortin 1 receptor. You know that the melanocortin receptor are the endogenous receptors for ACTH. Melanocortin type 2 is present on the adrenal. Type 1 is present on the skin, melanocytes of the skin. So when the ACTH is very high, it can bind to the melanocortin 1 receptors on the skin to produce hyperpigmentation. So these are the overall common clinical features of adrenal insufficiency. So in general, you think of AI in patients with unexplained fatigue, unexplained anemia and weight loss, worsening of this fatigue and lethargy during stress or fever, then the presence of salt craving, postural dizziness or postural hypotension, evaluation of hyperpigmentation. So these are the scenarios which warrants an evaluation for adrenal insufficiency. Now, now we are suspecting the patient to be suffering from adrenal insufficiency. How are you going to diagnose that? So the first or the initial screening investigation for AI is a serum cortisol, which is done in the morning around 8 a.m. So why do you sample for cortisol in the morning? It is because you expect the highest level of serum cortisol by 8 a.m., 9 a.m. So at the point of where you expect the highest concentration of cortisol, even then if you get a lower value, then it is more suggestive of adrenal insufficiency. So if you sample cortisol at other points of the day, like in the afternoon or at night, you expect the cortisol to be inherently low during that points of time. But in the morning, the cortisol levels are at the highest. And even at that point, if you are getting a low cortisol, then that is more significant. So, what level of cortisol is considered low? That again is a matter of debate. The Endocrine Society guidelines released in 2016 say that cortisol less than 5 microgram per deciliter is what you consider as low basal serum cortisol. But some textbook and articles say less than 3 micrograms per deciliter. So I use the cutoff of 3 micrograms per deciliter in my practice. But again, you have the backing from guideline to say that even less than 5 microgram per deciliter can be considered as low. So again, you will have to keep in mind the fact that not all low serum cortisol is due to adrenal insufficiency. So the patient may be receiving any form of exogenous steroid from any source. While evaluating a cause for hyponatremia, you have sent for serum cortisol and it has come back as low. It doesn't mean that that hyponatremia is caused by adrenal insufficiency. You want to make sure that there is no use of exogenous steroids. So many a time the patient takes so many supplementary medications and indigenous medications or certain topical preparations for fairness creams, something like that, that may contain steroids. So this will have an inhibitory effect on the HPA axis, but the patient will have no symptoms of adrenal insufficiency whatsoever. And the cause for hyponatremia could be something else. So in those situations, you should try to correlate that low serum cortisol to the clinical symptoms of the patient. So just an isolated low serum cortisol without any symptoms whatsoever, you should take it with a pinch of salt before making a diagnosis of AI. Always make sure that the possibility of exogenous steroids is being ruled out. Now, we have told that the 8 a.m. serum cortisol is the screening investigation for adrenal insufficiency. Now, what about the definitive investigation? So, for definitive diagnosis, you need to demonstrate the glucocorticoid deficiency in that individual. So, there is a dictum in endocrinology. So, endocrinology is a disorder of hormone, is a specialty of hormone imbalance. Okay, you are studying about hormone deficiency and hormone excess. So, in order to make a diagnosis of hormone deficiency, you need to use an stimulation test. And to diagnose hormone excess state, you need to use suppression test. So, this is basic logic in endocrinology. So, what would you use in adrenal insufficiency? It is a state of glucocorticoid deficiency. So, obviously, we will have to use a stimulation test. So, what is the agent that you use for stimulation? It is nothing but recombinant ACTH, which you call as synacthen or co-syntropin. You want to make sure that the adrenal gland is not able to produce enough amount of cortisol even after maximal stimulation with ACTH. In order to obtain that maximal stimulation, you give recombinant ACTH in the form of synacthen or co-syntropin. So how is it different from the native ACTH? The native ACTH has 39 amino acids, whereas the co-syntropin or synacthen contains the first 24 biologically active amino acids. Now, how to do a synacthen stimulation test? Almost all the residents would answer what is the definitive investigation for AI. Everyone will say synacthen stimulation test. But in practice, if you want to confirm the diagnosis of AI, then definitely you will have to be thorough with this investigation. So, how to go about this investigation? So these are the two preparations which were widely available. So Synacthen was an international brand, and this Syntropack was the brand which was available in India till recently. But unfortunately, currently it is out of stock and it is not being available to us for the past few months. Even approximately for a year, it is not being available to us. So what, even though you study that Synacthen stimulation test is the gold standard investigation for Addison, you are many a time not able to do that due to the lack of availability of this medicine. So how to do this test? You give 250 microgram of this Synacthen as IM or IV. Either of these route is okay. And irrespective of the time of the day, you can perform this test. In the morning, in the afternoon, in the evening, any time of the day you can perform, even though some of the textbooks say it is best interpreted in the morning. So if possible, try to do it in the morning, but even if you do it in the afternoon or evening, it is okay. But if you do basal serum cortisol, it always has to be in that 8 a.m., 9 a.m. time period. So after this 250 microgram injection, you take the sample for serum cortisol at 30 minutes and 60 minutes. So this is very important. You take the sample at 30 minutes and 60 minutes. Now, when do you make a diagnosis of adrenal insufficiency? Very important. If both the values at 30 and 60 are less than 18 microgram per deciliter, then only you can make a diagnosis of adrenal glucocorticoid deficiency. So this 18 microgram per deciliter, you should keep in your mind to answer in your viva as well as for your entrance examination. But in your practice, now the consensus has come that even with a lower cutoff of 14.5 to 15 may be used to rule out adrenal insufficiency. Probably in the next revision of the guidelines, this will be added on. So till then, you have to continue with the 18 microgram per deciliter for your exam purposes. But in practice, now we have shifted from the older 18 microgram per deciliter to the newer lower cutoff of 14.5 to 15. So this cutoff change had happened because of the increased sensitivity of the newer generation cortisol assays. Just keep in mind that if the patient has got a cortisol level of more than 15 microgram per deciliter after Synacthen, then the patient is not having glucocorticoid deficiency at that point of time. That is what this interpretation means. Now, I've told you the problem of Synacthen not being available in India. So as a resident who is doing the MD medicine in India, how can you confirm adrenal insufficiency? So even though Synacthen is not available, you have another preparation, which is ACTH linked to a carboxymethyl cellulose. This is what you call as long-acting ACTH. So this is a drug which we use for management of infantile spasm in children. So for infantile spasm, ACTH can be used, and this formulation, the long-acting ACTH formulation, is available in the market. So this is what you call as the actin prolongatum stimulation test. So actin prolongatum is the brand name for the long-acting ACTH preparation. So you have already learned the protocol for Synacthen stimulation test. Now we can look at how this actin prolongatum stimulation is different from the Synacthen stimulation test. So here you give 30 international units. 30 international units is approximately equal to 250 micrograms of ACTH. Okay, so that is why you give 30 international units. How do you take 30 international units? It is 0.5. 0.5 ml given intramuscularly, and the sample is taken after 1 hour and 2 hours. Note the difference with Synacthen stimulation test. In Synacthen stimulation test, the samples were taken at 30 minutes and 60 minutes. Here, it is taken after 1 hour and 2 hours. And the cutoff, you can use the same cutoff as that of Synacthen. The 18 and the 15 micrograms per deciliter cutoff you can use. So beware of this fact that if you want to confirm AI in your patient, you would have to resort to actin prolongatum stimulation test. Now, based on 8 a.m. cortisol, how are you going to proceed with the investigations? So if the 8 a.m. cortisol itself is more than 15 microgram per deciliter, then you can definitely rule out adrenal insufficiency. Now, if it is less than 5 microgram per deciliter or less between 5 to 15 microgram per deciliter, how are you going to go about? So if it is less than 5, then you should look at the ACTH level. So ACTH levels can either be more than 2 times the upper limit of normal or less than 2 times the upper limit of normal. We've already learned that when the cortisol is low, primary adrenal insufficiency, and there is no need, for further ACTH stimulation test. Then now what can be, if the cortisol level is between 5 to 15 micrograms per deciliter, then that is the time where you have to do ACTH stimulation test. Or in those individuals who are having cortisol less than 5 microgram per deciliter and the ACTH is less than 2 times the upper limit of normal, then also you should do ACTH stimulation test. So in nutshell, if the cortisol is more than 15, I'm talking about the basal cortisol. If it is more than 15, then you can rule out adrenal insufficiency. And if it is less than 5 microgram per deciliter with the ACTH more than 2 times the upper limit of normal, then of course, what you can do, more than 2 times the upper limit of normal, then you can make a diagnosis of primary adrenal insufficiency. Okay, so in nutshell, primary adrenal insufficiency, patients would have 8 cortisol less than 5 or ACTH stimulated serum cortisol less than 18 microgram per deciliter along with ACTH levels more than 2 times the upper limit of normal. So ACTH more than 2 times the upper limit of normal should be present along with the low basal or stimulated serum cortisol. The cutoff is 5 microgram per deciliter and 18 microgram per deciliter respectively. Now, what about secondary AI? Secondary AI, you always should resort to the ACTH stimulation test. Just by doing a basal serum cortisol, you should not readily make a diagnosis of secondary AI. You will need to use ACTH stimulation test along with ACTH less than 2 times the upper limit of normal. Now, you may wonder, in a patient with secondary or central adrenal insufficiency, already your adrenal gland is normal. Only either your pituitary or hypothalamus is defective. Then how can you use ACTH stimulation test? Because already your adrenal is normal and you expect normal response by the adrenal when ACTH is given. So how can you then make use of ACTH stimulation in a patient with central AI? So this is a question which is often coming up in the minds of residents. Let's look at the explanation. So in pituitary or hypothalamic disease, adrenal glands are structurally and functionally normal. Just a case of pituitary radiotherapy or pituitary surgery. The ACTH is gone, but the adrenals are structurally normal. But in a patient with long-standing ACTH deficiency of more than 6 weeks, what happens is that this ACTH is required for the trophic action of the adrenocortical cells. When that ACTH action is gone, it will result in adrenal atrophy. So when long-standing pituitary or hypothalamic disease is there, the adrenals will get atrophied, and this atrophied adrenal cannot result in cortisol response following ACTH injection. So that is the reason why you are still able to use an ACTH stimulation test. So in a patient with secondary AI. But if you are asked which is the gold standard test for central AI, it is insulin tolerance test, where you induce hypoglycemia and the ACTH response to the insulin mediated hypoglycemia is looked at. So very important, if the patient is suspected to be having a central adrenal insufficiency which is of recent onset, that means the patient has had a surgery 2 weeks back, pituitary surgery 2 weeks back. Now, if you want to look at whether the patient has got adrenal insufficiency or not, then you should not use ACTH stimulation test. Why? Because the adrenals need at least 4 to 6 weeks to undergo atrophy. If you are giving ACTH within that time frame, the adrenals will be able to respond to the ACTH that you are giving, and even in the setting of ACTH deficiency, your cortisol levels will rise. So ACTH stimulation test can be used for diagnosis of AI in all cases of primary adrenal insufficiency and in long-standing disease of secondary adrenal insufficiency more than 6 weeks duration. That is the take-home message from this slide. Now, can we test cortisol in a patient who is taking glucocorticoids? Many a time, a patient may present to you in adrenal crisis-like situation, in hypotension, hyponatremia, in a life-threatening situation. So at that point of time, you may not get time to do the serum basal cortisol, ACTH stimulation testing and all. You will have to give the rescue treatment at the earliest. So there are certain situations, especially in emergencies, where you will have to administer steroids before confirmation of adrenal insufficiency diagnosis. So the problem is that hydrocortisone that you are giving as injection or tablet is exactly the same as endogenous cortisol. So in a patient who is taking hydrocortisone, all that hydrocortisone will be measured by the assay as serum cortisol. So the serum cortisol value will be erroneously high in a patient who is getting hydrocortisone. So always make it a point that serum cortisol testing should be done at least 24 hours after the last dose of hydrocortisone. The IV hydrocortisone has a half-life of around 4 to 6 hours. So you make sure that 3 to 4 half-lives have already passed before you do a serum cortisol testing in such individuals. And very importantly, dexamethasone won't interfere with the cortisol assay. So if you are giving dexamethasone IV, that dexamethasone will not be measured by the cortisol assay. So if you want to give a bolus dose of steroid and doesn't want it to interfere with the cortisol assay, then dexamethasone is the preferred glucocorticoid agent. But also make sure that the patient is not in dexamethasone for a long period. Why? Because this dexamethasone will cause a persistent HPA axis suppression. So 1 or 2 doses of dexamethasone may not result in such HPA axis suppression. But if the patient is receiving dexamethasone for a long period of time, then there is no point in testing the cortisol because it is always going to be low because of the potent HPA axis inhibitory effect of the dexamethasone. Now, the next question is that you suspected AI in this patient, you confirmed AI with the help of Synacthen or actin prolongatum stimulated serum cortisol. Now, I've made a diagnosis of AI. So do I need to test mineralocorticoid axis also in these patients? Answer is yes if it is a primary AI and no if it is a secondary AI. Why don't we why there is no need to test for renin and aldosterone axis in secondary AI? Because the ACTH is not regulating the aldosterone function, rather it is the RAS. So mineralocorticoid deficiency is associated with most cases of glucocorticoid deficiency. So in primary AI, whatever be the etiology, be it autoimmune adrenalitis, be it tuberculosis, be it fungal infections, all these etiologies will affect this glucocorticoid as well as mineralocorticoid producing cells. So if the patient is having glucocorticoid deficiency, then there is every chance that the patient is having a coexistent mineralocorticoid deficiency as well. So what happens if you are not testing and not treating mineralocorticoid deficiency? So then the symptoms which are due to mineralocorticoid deficiency would persist, like the postural dizziness, the postural hypotension, salt craving, everything will persist. And we have learned that even mineralocorticoid deficiency will result in fatigue. So the patient may be on optimal glucocorticoid replacement, but is still complaining of fatigue, which is actually due to mineralocorticoid deficiency. But you feel that the fatigue may be due to glucocorticoid deficiency, and you will keep on increasing the dose of glucocorticoids, resulting in glucocorticoid excess, over excess, resulting in toxic features. But still the patient will not get relieved of the fatigue. So in order to reduce the dose of glucocorticoids and to get good relief of symptoms, it is very important to test for mineralocorticoid axis in all patients with primary adrenal insufficiency. And which is the preferred screening investigation? It is the plasma renin activity. So plasma renin activity is the preferred screening investigation for testing the mineralocorticoid hypofunction. Now, another question, can I check for adrenal insufficiency during critical illness? Very pertinent question. The patient may have come with another condition like septic shock, or the patient may have decompensated chronic liver disease. So unrelated illness, but the patient may be having some features of adrenal insufficiency like hyponatremia, then patient may be having hypotension. So we are not sure whether there is a coexistent adrenal insufficiency also. But you know that in critical illness, your cortisol level also increases, and your standard cutoffs that you use for diagnosing AI is not applicable for critical illness. But there have been certain studies which have empirically stated certain cutoffs, but this is not definitive cutoffs endorsed by the guidelines. These are certain parameters with which certain research papers have been done. So in a patient in critical illness, basal cortisol less than 15, stimulated cortisol less than 33, and delta cortisol. Delta cortisol means the difference between the stimulated cortisol and the basal cortisol. If it is less than 9 microgram per deciliter, all these are indicative of critical illness related corticosteroid insufficiency or CIRSI. So this is the method with which you can identify a relative adrenal insufficiency occurring during periods of critical illness. Now, once you have made a diagnosis of adrenal insufficiency, the next part is to have an etiological workup. The common etiologies for adrenal insufficiency, the two most common in our setting are tuberculous adrenalitis and autoimmune adrenalitis. But you should also keep in mind the other possibilities like adrenal hemorrhage, metastasis, fungal infections, and rare conditions like adrenomyeloneuropathy or the AAA syndrome or the Algrove syndrome, etc. So all these are possible causes for adrenal insufficiency, and you should look for any clues regarding the diagnosis from history and clinical examination. I'll tell you some examples. So suppose a patient with Addison disease is having a history of Hashimoto's thyroiditis or Graves' disease or premature ovarian insufficiency, type 1 diabetes or vitiligo. All these are autoimmune conditions. So if one more autoimmune condition is there, you should strongly think of the possibility of autoimmune adrenalitis. Likewise, a patient with a present or previous history of pulmonary tuberculosis or now is having intermittent evening rise of temperature with chills, you should think of the possibility of tuberculous adrenalitis. In a patient with adrenal insufficiency who is immunocompromised, who is having neutropenia or is HIV positive, think of the possibility of invasive fungal infections, most commonly histoplasmosis. Then a patient who had history of abdominal trauma or use of anticoagulants now presenting with adrenal insufficiency, you think of adrenal hemorrhage as a possible etiology. A patient with long-standing spasticity, that human findings, then peripheral neuropathy, higher mental function abnormality, now having adrenal insufficiency, you think of adrenomyeloneuropathy. Then, of course, these rarer possibilities like alacrimia, then dysphagia due to achalasia cardia, and autonomic dysfunction. All these can be due to AAA syndrome. So these are the pointers that you will ask from history to get a clue regarding the possible underlying etiology. And also a patient who is a non-case of solid organ or hematological malignancy, you should adrenal metastasis or lymphoma. And very importantly, unilateral adrenal mass or metastasis will never result in adrenal insufficiency. It has to be bilateral, and more than 90% of the adrenal cortex is the bilateral lesions which is causing AI. So coming to the next point. So once you have made a diagnosis of AI, you have looked at the history and clinical examination. Afterwards, the most important investigation, if the etiology is unclear. So definitely if you have an autoimmune association or the patient is having a disseminated metastasis or is having disseminated tuberculosis, then of course there is no need for further investigation. Your diagnosis is clear. But if the etiology is unclear, the investigation that you will have to proceed to is CT abdomen with contrast. So CT abdomen with contrast is the next investigation that you should proceed to. Okay. So here in this session, I am limiting my discussion to the diagnosis part only, because the treatment part itself is a huge chunk of information. So I would not want to take an exhaustive session. I'll just limit with this diagnosis. I'll just stop with the diagnosis part, and we'll just have a look at certain case scenarios that we have worked up in our department. So just see some case scenarios. So a 64-year-old male presented with fatigue, abdominal pain, and recurrent episodes of vomiting. Also had weight loss of around 10 kilograms in 1 to 2 months, and evaluated in local hospital, detected to have hyponatremia, also having hyperpigmentation over the face. So every clinical features that we have studied under adrenal insufficiency is being listed here. The fatigue, weight loss, vomiting, then hyperpigmentation, hyponatremia, everything is given. So when we looked at the investigations, the stimulated cortisol was low. It is less than 18 with the ACTH level more than 100. So this, we made a diagnosis of biochemical adrenal insufficiency, and we have looked at the CT abdomen of this individual. Mind you, this patient didn't have any other symptoms. This is the right adrenal area. So this is your kidney, and this is the right adrenal. You can see the bulky right adrenal. And in the area of left adrenal, you can see two spots of calcification. So bilaterally enlarged adrenals with calcifications. So you are thinking of something which is infiltrating the adrenals. So we proceeded with the CT guided biopsy, and the biopsy had shown numerous granulomas with central caseating necrosis and giant cells. So our diagnosis was primary adrenal insufficiency, bilateral adrenal mass due to adrenal tuberculosis. There was no evidence of tuberculosis elsewhere, and the workup for everything was negative. The sputum AFB, the sputum CBNAT, everything was negative, but the manto was strongly positive. So this is a case of adrenal tuberculosis presenting as adrenal insufficiency. So here the imaging has shown enlarged adrenals due to infiltration, and the biopsy had shown evidence of necrosis along with the granulomas. So the patient had completed 6 months of anti-tuberculous treatment. Now you can see the adrenal glands which were enlarged like this. Now it has shrunken in size. But mind you, in many cases with adrenal tuberculosis, even if you give anti-tuberculous treatment, the destruction of the adrenocortical cells are sometimes permanent, and they may have permanent adrenal insufficiency. So that is one thing that you will have to keep in mind. The treatment with ATT will not cause a recovery of adrenal function in majority of the cases. So case number 2, a 28-year-old male presented with history of recurrent episodes of vomiting and fatigue. She is a non-case of primary hypothyroidism with anti-TPO positivity. Diffuse hyperpigmentation was there. Serum cortisol was less than 0.5, and ACTH was more than 2000 picograms per ml. Again, there is no diagnostic confusion. The suggestive clinical scenario is there, and the lady or the person is also having history of Hashimoto's thyroiditis. So there is an association with other autoimmune conditions. So naturally, we proceeded with the imaging investigation, which showed bilateral atrophic adrenals. So atrophic adrenals in a patient with primary adrenal insufficiency with an autoimmune association, you think of autoimmune adrenalitis, which should be confirmed with 21 hydroxylase antibody assay. But this 21 hydroxylase antibody is not widely available. So even if you don't do that antibody assay, you can still make a probable diagnosis of autoimmune adrenalitis by combining the biochemical, the radiological finding of atrophic adrenals, and the association with other autoimmune conditions. So this autoimmune adrenalitis is a unique condition for causing atrophic adrenals. And apart from this autoimmune adrenalitis, certain rarer genetic conditions like the Algrove syndrome and all can also result in a or atrophic adrenals, but all the others will have a normal or an enlarged adrenal glands. So we look at another case, a 54-year-old male presented with complaints of bleeding per rectum associated with constipation and significant loss of weight. On examination, and investigation, he was found to have carcinoma rectum. So along with that lesion in the rectum, CT abdomen also showed bilateral adrenal masses. So here the patient, though he had fatigue and loss of weight, it was attributed to the malignancy, which is carcinoma rectum. And when we did the evaluation, the stimulated cortisol was 13.5 and the ACTH level was also more than 100 picograms per ml. So this was the imaging finding. You can see the infiltration of the right adrenal as well as the left adrenal. So both the adrenal glands are enlarged in a patient on the background of carcinoma rectum. And because a suggestive clinical history was there, we didn't go for guided biopsy. And the possible diagnosis of CA rectum with bilateral adrenal mets was kept. And the scenario was also suggesting the same. So later he underwent chemoradiation followed by anterior resection for rectal adrenal lesions have reduced. That again is a corroborative evidence to say that it was in fact the metastasis from the carcinoma rectum which has responded to the chemoradiation that we have given to the patient. So coming to the last case, a 67-year-old male with complaints of abdominal pain, vomiting, and fatigue with significant weight loss and loss of appetite is now evaluated and found to have hyponatremia. So on evaluation, one significant point was the patient was having multiple cervical lymph nodes. So multiple lymph nodes in a patient on the background of adrenal insufficiency. So the adrenal insufficiency was diagnosed with the help of a basal ACTH of 127 and a basal serum cortisol of 3. So 3 microgram per deciliter cortisol and a high ACTH doesn't even warrant an evaluation with ACTH stimulation test. Have made the diagnosis of primary A, possibility of tuberculosis, think of the possibility of certain rare infections, granulomatous disorders, and certain malignancies like the lymphoproliferative neoplasms. So here, the patient's chest X-ray had also shown mediastinal widening, and this is the CT abdomen. We did as per protocol. There was massive enlargement, massively enlarged adrenals with large masses of around 5 and 6 centimeters. The area also showed multiple enlarged hilar and mediastinal lymph nodes. And we did the guided biopsy from the adrenal, which has shown the lymphoproliferative neoplasm, the monomorphic proliferation of lymphoid cells, small round blue cells with CD45 or the leukocyte common antigen positive and CD20 positive, suggestive of non-Hodgkin's lymphoma, B cell lymphoma of non-Hodgkin's variety. So now we have had a discussion on a spectrum of conditions which were workup in our department, and we have also some certain rarer conditions in the store like the adrenomyeloneuropathy, the familial glucocorticoid deficiency, the descriptions of which I have included in the proper curriculum course, which you would find it very interesting. So in this patient, the final diagnosis was primary AI in a patient with bilateral adrenal mass, which eventually turned out to be a lymphoproliferative neoplasm. So I would stop my discussion here because going into the treatment and the management aspect would take too much time. I have covered that aspects in great detail in the curriculum residency course. You can, once it is launched, you can very well go through that for full information on adrenal insufficiency. So after this session, the take-home points I would suggest that you should keep in your mind is that you should have high suspicion of adrenal insufficiency based on the features that we have already learned: the fatigue, the weight loss, hyponatremia, hyperpigmentation. In all such situations, you should keep adrenal insufficiency as a possible differential diagnosis. And always start with basal serum cortisol. If it is low, you do ACTH and you do ACTH stimulation test when indicated. If the serum basal cortisol itself is more than 15, there is no need. If the serum cortisol is less than 5 with a high ACTH, then also there is no need. So in all cases of AI, there is no need for doing an ACTH stimulation. Only when it falls, cortisol level falls in the intermediate range, or when you have a diagnostic confusion, you go for ACTH stimulation. And keep in mind, secondary AI will have normal or low ACTH level. That normal point is very important. So ACTH levels will not always be suppressed in secondary AI. It can well be normal. The crux is it will not be elevated. It will be elevated only in primary adrenal insufficiency. So why is this important? Because the crisis is less likely in a patient with secondary AI due to intact aldosterone system, and also the hyperkalemia as well as the need for fludrocortisone replacement is also not there. So that is the importance of distinguishing primary AI from secondary AI in therapeutic as well as management purpose. And in our Indian setting, the Synacthen, because it is not available, you can do the actin prolongatum stimulation test. Very importantly, it should be given only as IM injection, 0.5 ml, not as IV. And the time frame is also slightly different from that of Synacthen. Synacthen, you take it 30 and 60 minutes. Actin prolongatum, you take it 1 and 2 hours. And you should also be aware of the revised cortisol cutoff. The cutoff has been brought down from 18 to 15. So, but still it is endorsed in the guidelines. You can still go for the 18 microgram per deciliter for your exam purpose and for 15 microgram per deciliter for your clinical practice. And you should always actively search for any clues regarding etiology, and you should do CCT abdomen in all patients, because that would help you in identifying the lesion. Atrophic adrenals would be seen in autoimmune etiology. Enlarged adrenals with necrosis is seen in tuberculosis. Calcification is seen in chronic conditions like tuberculosis as well as organized adrenal hemorrhage. Then once you get an imaging done, then it is easier to do a biopsy for getting the final diagnosis. So with this, I would like to conclude today's session. So any questions you can type in the YouTube live chat box. And here I have put the QR codes of the two WhatsApp discussion groups that we are currently running. One is the endocrinology discussion group, WhatsApp discussion group here, this QR code. And this is one group that we have started recently for the medicine residents who are targeting the 2024 NEET SS exam as well. So we will be actively posting questions and updates which will be useful for your practice as well as for your entrance examination in these groups. So those who are interested can scan these QR codes and very well join and take part in the active discussions. So any questions regarding adrenal insufficiency, the diagnosis, the evaluation, management, whatever, if you have any questions in your mind, I would be happy to take them. So once again, I want to stress one fact that this medicine residency course is an entirely different course, both in the structure, in the content, and how we have approached the topics as well. It is extremely, or it is totally different from the already existing NEET SS or INISS packages that we are providing, because we have tried to include many of the real life case scenarios. This is not a case scenario which is made up or it is taken from internet. These are all the real life case scenarios that the faculty have worked up in their experience, and we are sharing it with them. So that would make you more insightful, and rather than just reading the theory and going through the algorithms or guidelines, here you will be getting a practical approach. You know, just if you are not worked up a case of adrenal insufficiency, you have read AI from just a textbook, be it Harrison, Williams endocrinology or Up to Date, they would just tell you about this short Synacthen test. But when you try to do a short Synacthen test for a patient, you will get to know that it is no longer available in our country. So what is the alternative? Nothing of this sort is given in your textbook. So that is where our role come into play, where we are sharing the practical experiences that we have accumulated over the years, and that we believe would be extremely helpful for you, and that would help you lay a strong foundation from which you can build with your own reading as well as for your preparation, and it would serve you in a good purpose for your upcoming entrance examinations as well. So the launch of the medicine residency course will occur in this month end itself, within this month itself. So the details of the packages will soon be advertised in the WhatsApp groups and in the social media pages. So please stay tuned. And I think that would be a great addition as a great knowledge resource for you, because you have all the national faculties, the experts in each and every field taking the individual subjects, and it would be great to have insights from them for your preparation as well. So if there are no questions, I think I shall sign off. Thank you. Have a good day.